Hi, Muhammad Al-Mala here. Today we're going to talk about an important topic, which is how to center a Clearview multifocal intraocular lens. IOL centration is, of course, a very important topic, but especially when it comes to centering a multifocal intraocular lens. As you can see, the case has already started. We've already put in preservative-free lidocaine. We've filled the anterior chamber now with viscoelastic. This is visco. We're using 0.12 forceps to hold the paracentesis and a 2.4 millimeter keratome blade to make the main incision. If you watched my videos before, you know that I love to fixate the globe with the 0.12 forceps. It gives me a lot of control when I make my main incision, as well as when I do the capsular rhexis. Significantly decreases the stress of this part of the surgery. With the cystitome there, we raised the capsular flap with just one continuous motion, and now we're going to use our capsular rhexis forceps to create a continuous curvilinear capsular rhexis. So far, so good. And then we're going to use BSS on a cannula to hydrodissect. We're going to do a cortical cleaving hydrodissection, which means we're going to lift the capsule up, tent up the capsule. You see the triangle sign there. One continuous fluid wave, and we've got our hydrodissection, a cortical cleaving hydrodissection. Then we'll go in with Phaco, and my technique is a Phaco Chop technique. So I'll go in with Phaco through, of course, the main wound, and then I'll use my chopper. This is an Nagahara chopper, and we will use that to start our Phaco emulsification and nucleus removal. So we bury the tip here into the nucleus. We reach around with the chopper around the equator, and we crack the nucleus in half. We've got a nice crack here. Got two heminuclei now. Same thing, we're going to split this into quadrants. Also a nice split there. So we got one heminucleus split into two quadrants. Very nice rotation. And we will do the same thing here with the other heminucleus. Once we've split, we can go ahead and start removing. I actually use the same Phaco mode through all of this. I use Torsional Phaco from 20 to 50 power, and we are using intelligent Phaco, which means as the probe gets close to occlusion, it gives us a little bit of longitudinal Phaco to clear the tip, and that keeps the pieces moving. I like to see those pieces tumble like that. It's the most efficient way for them to be taken up by the probe. And we'll just work here slowly and remove the nucleus. You'll see there I'm using my second instrument already behind my Phaco probe, just to keep anything in the posterior capsule from coming forward. It's probably not as necessary at this stage. Perhaps I'm being overcautious here, but definitely when it comes time to remove the last piece. In any case, our case here is progressing nicely. We have one quadrant left. Usually I try to leave the largest quadrant for last, and that way we have the most room inside the capsular bag and anterior chamber for this piece to tumble. So very nice. Everything's going very well here. I do see already that I still have some cortex remaining despite the cortical cleaving hydrodissection, and that's okay. We'll use IA here to remove those cortical remnants and piece of cortex there. We have some here to the left of the screen and also subincisionally. I do that with the BSS cannula there. If you'll notice, I irrigated the paracentesis. Sometimes there can be pieces of nuclear material in the paracentesis, and so we want to get those out. And it just gives me something to do while my scrub tech gives me the IA handpiece. So we'll remove the remaining cortex there with the IA handpiece. And then once we have all of that out, I'll polish the posterior capsule. I'll use a Terry Squeegee, which is a cannula with a silicone tip, to polish the posterior capsule centrally. And I really do that for almost all my cases. You'll see here there's just a little bit of material there. Does this really make a huge difference? I'm not entirely certain, but I don't like looking at that, especially if it's in the center of the posterior capsule. I'm injecting Provisc now. I go to both the left and the right of the main wound. And the reason I do that is because I want to get out any remaining nuclear fragments that may be in the anterior chamber angle. So we're going to do a Clearview IOL in this case. This lens can either be on an inserter which you twist or you push. I like to use the push inserter that frees up my second hand to stabilize the globe. I'll put a corner wand through the paracentesis. It keeps things nice and centered. And then I'll go ahead and inject that IOL. This is a hydrophilic acrylic IOL. So it has a, so when you notice here on the haptic closest to us, has a little indentation there on the left there. And it also has a little circle. That indicates that you're looking at the near segment. The Clearview IOL is a segmented IOL. You'll see a line there going across horizontally in the screen. The segment that's further away from me is a distance segment. The segment that's closest to me is a near segment. And now pay attention to this part. This is where we talk about centration. There are two Purkinje images that we see here very prominently. The one you see now, right in the center, with the small, with one circle up top and the two circles in the bottom, that's Purkinje Image number 1. That's coming off the cornea. The second one, which you see moving around here, which is inverted, is Purkinje Image number 4, and that's coming off the posterior surface of the intraocular lens. Now you'll notice right now that they're not really lined up, and the fourth Purkinje image is really moving around all over the place. They're the third Purkinje image, which is not relevant here, but that's a third Purkinje image, which is much larger and also in view here. But what we're looking at is lining up the first and fourth Purkinje image. The fourth Purkinje image is moving throughout the surgical field here. But if you think about it, what is that fourth Purkinje image? And when we line it up with the first Purkinje image, what that means is that the IOL is orthogonal to the cornea. And whenever the fourth Purkinje image is to one side or the other, then the IOL is tilted. So if the IOL is orthogonal to the cornea and the two Purkinje images line up, whatever part of the intraocular lens is right below those two Purkinje images will be exactly where the center of the cornea is, or the corneal apex. So when you line up those two images, whatever part of the IOL is there, that will be the part of the IOL that will be right below or orthogonal to the corneal apex. So you want the center of the IOL to be centered with the corneal apex. So I spent all that time explaining that, and we didn't really get to see what was happening with those two Purkinje images and why I chose to center it where it is. So I'm going to replay this part of the video, and we're going to pay more attention to how those two Purkinje images align with each other. Here we see 1, 2, here we see 1, 3, and 4 Purkinje images here. First in the middle, third up top, fourth in the bottom. And when we line up the first and the fourth, whatever part of the IOL is underneath is the part of the IOL that lines up with the corneal apex. If it's a multifocal IOL that's a diffractive optic, you want the central button to line up there. Here, with the Clearview, what we want is the Purkinje images to favor the distant segment. We want it to be well-centered, but we want the Purkinje images to favor the distant segment. That's how these patients do well. So let's go ahead and go back here a little bit, and let's see what we did here when we came to line up these lenses, when we came to line up this lens. So here the lens goes in again, and we'll just forward here. So we'll use a corner wand to push the IOL into the capsular bag. So, and then we'll do IA again to remove the viscoelastic. And look at the fourth and first Purkinje images here. The near segment is towards the incision. And as we remove the viscoelastic, we'll see that they line up really kind of over the center here. we want to put the segment, the manufacturer says to put the near segment and either the infranasal, or and that's I think the on-label use, or the supratemporal. And I will do it based on how these Purkinje images line up. So there we go. I line up the Purkinje images there, and what I see is they're favoring the near segment. So here they're lining up more over the near segment than the distant segment. It's subtle, but it's important to see this. Here, when I line up the Purkinje images, they're favoring the distant segment, the one on the left. Yes, they're favoring the distant segment, and that actually looks like a pretty good position for this lens. But nonetheless, I am rotating the lens, and I'm going to check in multiple quadrants here to see where this lines up the best. This also favors the distant segment here. So I line up the first and fourth, and as I line up the first and fourth here, this now favors the near segment. The near segment is on the left side, and so we don't want to leave it this way. The manufacturer recommends lining up the Purkinje images to favor the distant segment. So now we're over the distant segment. It favors the distant segment. It's pretty close to the center, but it does favor the segment on the right-hand side of the screen here, which is a distant segment. So I think here, I may leave it here. I think it looks like I'm going to leave it here. So that's where we left it. And then I'm going to hydrate the wounds and make sure the chamber is the way I like it. And once again, I'll just check to make sure that those two Purkinje images look like they favor the distant segment. And I see that little area, little piece of cortex there, so I'm going to go back in with IA just to clean that out. But in any case, that's how I center my Clearview IOLs, and I've had really good success with this lens. Patients do much better than I expect. I always think this lens shouldn't work the way it does, but it does. It works really well. Patients have, very often they have J1 plus for near, 20/20 or 20/25 for distance, and overall very happy with this lens. Overall, the patients are very happy with this lens. This is not the lens I use most commonly, but when I do use it, I've had good results with it. And I think the key to that is to center the IOL properly and make sure the Purkinje images favor the distant segment rather than the near segment. Well, I hope you learned something from this video. Please let me know your thoughts. Do you use this lens? If so, how do you center it? Do you spend this much time trying to center the lens and orient it properly? Would love to hear feedback from other surgeons as well. Thank you very much for your attention.